I'm Dr. Michael Hervey, a board-certified OBGYN, trauma-informed physician, and an advocate for protecting patient autonomy while preventing birth trauma inside the hospital setting. Several times a month, I sit across from a patient who is 35, 36, 37 weeks pregnant, and she hears words she did not expect. Your baby is Breech. And in that moment, everything changes. The birth plan changes. The anxiety changes. The conversations change. And very often, the options suddenly feel like they disappear. I want to talk about breech birth today because this is one of the places in modern obstetrics where patient autonomy, hospital safety, physician training, midwifery care, fear, liability, and real human emotion all collide. And I want to be very clear from the beginning. This is not a video telling you to reject medical advice. This is not a video encouraging rogue behavior. This is not a video saying every breech baby should be born vaginally. That would be irresponsible. This video is about something deeper. It is about informed choice. It is about honest counseling. It is about the difference between saying, you have no options, and saying, here are the options, here are the risks, here are the limits, and here is what can be done safely in this environment. Because patients do not need fantasy, they need the truth. A breech baby is a baby who is positioned bottom first, feet first, or buttocks first instead of head first. At term, this happens in a small percentage of pregnancies. It is not rare, but it is not common either. And when it happens, the standard recommendation in most hospitals is a planned cesarean section. That recommendation exists for real reasons. Breech birth can carry increased risks, including head entrapment, cord prolapse, birth injury, oxygen deprivation, emergency surgery, and in the worst-case scenario, death. So when I counsel a patient with a breech baby, I do not minimize that. I do not sugarcoat it. I say very directly, this is higher risk than a head-down vaginal birth. A C-section is the standard recommendation. If you choose a cesarean, that is medically reasonable. If you choose to explore other options, we have to talk very carefully about whether those options are safe, appropriate, and available. That is informed consent, not fear, not coercion, not abandonment. Consent. Here is where the system often fails. Many patients are told, your baby is breech. You need a C-section, period. End of conversation. No discussion of ECV. No discussion of the type of breech. No discussion of fetal size, head position, fluid level, placenta, prior birth history, provider experience, hospital protocol, or what safety resources are available. And when patients feel dismissed, some will leave the hospital system completely. That is where things can become dangerous, because there is a difference between respecting birth physiology and ignoring risk. There is a difference between honoring patient autonomy and pretending that every environment is equally safe. There is a difference between midwifery wisdom and attempting a delivery beyond the limits of training, setting, backup, or scope. We have seen tragic examples, including here in Arizona, where breech birth ended in devastation. When a breech patient is pushed out of one system and not safely received by another, the patient is left in the most dangerous place possible, between systems, and that is unacceptable. When I sit with a breech patient, I often say, I am not a cowboy. That matters. A vaginal breech delivery is not something I force. It is not something I chase. It is not something I induce. It is not something I augment. It is not something I perform to prove a point. A vaginal breech birth only happens if the conditions line up. The right patient, the right baby, the right labor, the right hospital, the right team, the right consent, the right moment. And even then, safety comes first. A C-section is always offered. A C-section is always available. And if the clinical picture changes, we move. No drama, no ego, no hesitation. One of the most important conversations in breech care is external cephalic version, or ECV. That is the procedure where a trained provider attempts to turn the baby from the outside of the abdomen so the baby becomes head down. This should not be presented as a circus trick. It should not be presented as someone putting their body weight on your baby for 30 minutes. That is not how I view it. A thoughtful ECV is controlled. It is monitored. It is usually quick. It is done with ultrasound guidance or ultrasound confirmation. It is done with fetal monitoring. And it is done in a setting where emergency cesarean delivery is available if something unexpected happens. ECV does not always work, but for appropriate patients, it should be offered. And when a patient tells me, "No one offered that to me," I pay attention, because educated patients make educated decisions. You cannot choose what you were never told existed. Let me give you a composite scenario. This is not one patient. This is a de-identified example built from common clinical situations. A patient comes in around 35 or 36 weeks. She planned an out-of-hospital birth. She is deeply afraid of hospitals. She has medical trauma. She has anxiety around needles, monitors, IVs, operating rooms, all of it. Then she finds out her baby is breech. Her midwife does the right thing and says, "This is outside what I can safely manage in this environment. You need a hospital-based consultation." So now this patient is sitting in my office. She is not reckless. She is not difficult. She is not trying to endanger her baby. She is afraid, and fear matters. If the first thing she hears from me is, "Absolutely not, C-section only, no discussion," I may win the medical argument and lose the patient. So instead, I slow down. I explain the situation. I say, "Your baby is breech. The standard recommendation is a planned C-section. That is the most common and accepted pathway in most hospitals. But that does not mean you do not deserve a full conversation." Then we review the options. Option 1, planned cesarean. Option 2, ECV if there are no contraindications. Option 3, if the baby remains breech, a carefully selected trial of vaginal breech birth may be discussed, but only under strict criteria and only with the right safety structure. Then I tell her the truth. If you come to the hospital under my care, I will offer you a C-section first. That is the standard. But if you decline, and if you remain an appropriate candidate, and if labor happens on its own, and if the baby tolerates labor, and if the team and operating room are ready, then we can discuss whether continuing is reasonable. That is not rebellion. That is medicine. That is patient autonomy inside a safety framework. Not everyone is a candidate for vaginal breech birth. That needs to be said clearly. In general, the conversation becomes more reasonable when there is a term baby, reassuring fetal status, an estimated fetal weight in a reasonable range, no major fetal anomaly, no hyperextended fetal head, no placenta issue blocking delivery, and a breech type that is more favorable. Prior vaginal birth can increase confidence. A frank breech is often more favorable than a footling breech. A footling or double footling breech is usually a major red flag because of cord prolapse and delivery complications. If the baby is transverse, that is not a vaginal delivery. If the fetal tracing is not reassuring, we move. If labor stalls, we move. If the patient cannot push effectively when needed, we move. If the room becomes unsafe, we move. That is the difference between autonomy and chaos. Autonomy does not mean anything goes. Autonomy means the patient receives honest information and makes informed decisions inside the boundaries of safety, skill, and reality. Now let us be honest about the hospital side. Many hospitals resist vaginal breech birth because many physicians are no longer trained to do it. That skill has been fading for decades. Some people call it the lost art of vaginal breech birth, and they are right. Doctors like Dr. Stuart Fishbein and others have continued to speak publicly about informed decision-making, physiologic birth, breech birth, twins, and the loss of breech skills in modern obstetrics. Whether someone agrees with every viewpoint in that birth community or not, the larger point is real. If no one teaches breech, no one learns breech. If no one learns breech, no one offers breech. If no one offers breech, patients are left with fewer options. And when patients are left with fewer options, some leave the system entirely. That is not safer. We need a better bridge, not arrogance from physicians, not recklessness from birth workers, not fear-based counseling, not abandonment. We need collaboration. When I counsel a patient considering vaginal breech birth, I set very clear rules. Spontaneous labor only. No induction for breech. No Pitocin to force the issue. Continuous fetal monitoring. IV access. Operating room available. Anesthesia aware. NICU or neonatal team available. Experienced hands in the room. Clear plan for immediate cesarean if needed. And the patient must understand her role. I tell patients, know yourself, know your pain tolerance, know your limits. If you are choosing an unmedicated breech birth, you must be able to listen and respond even when the room gets intense. If I tell you to stop, push, rotate, change position, or move to the OR table, I need you with me. If you reach the place where you cannot do that safely, then we move to C-section. That is not control. That is partnership. Patient autonomy does not mean the physician disappears. It does not mean the hospital has no standards. It does not mean the patient carries all the risk alone. True autonomy means I respect your right to make decisions about your body, but I also respect you enough to tell you the truth. If something is unsafe, I will say it. If something is possible but limited, I will say it. If something depends on hospital policy, provider skill, and real-time labor conditions, I will say it. And if I cannot safely offer what you want, I should not shame you. I should help you understand why, help you find the safest pathway available, and never abandon you. That is the standard patients deserve. So if your baby is breech, here's what I want you to ask. Am I a candidate for ECV? What type of breech is my baby? Is the baby's head flexed or extended? What is the estimated fetal weight? Where is my placenta? How much fluid is around the baby? Does this hospital have a protocol for vaginal breech birth? Is there a provider here experienced in vaginal breech delivery? If I decline a C-section, what happens next? Will I still be cared for respectfully? That last question matters, because patients should not have to agree with the first recommendation to be treated with dignity. Breech birth is not simple. It is not something to romanticize. It is not something to fear so much that we refuse conversation. A C-section can be the right choice. ECV can be the right choice. A vaginal breech birth in a very selected setting with an experienced provider and a prepared team can sometimes be the right choice. The problem is not that we have standards. The problem is when standards become silence. The problem is when patients are told what will happen instead of being taught what is possible. The problem is when fear replaces informed consent. My message is this: you deserve options. You deserve safety. You deserve honesty. You deserve a provider who will tell you the truth without taking away your voice. Because birth is not just about getting through the event. It is about how you are treated while you are getting through it. And when we protect safety and autonomy together, we protect more than birth. We protect trust. If this conversation matters to you, share this video with someone who is pregnant, someone who supports birth, or someone who has ever been told you have no choice. And if you are facing a breech pregnancy, do not make decisions from fear. Ask questions. Get informed. Understand your hospital's policies. Understand your provider's experience. And make the decision that is safest and most aligned with your values. This is Protected Birth. Safety, autonomy, respect, real.